Good afternoon again, everyone. We're going to give it about another 60 seconds here to fill the room. Good afternoon, everyone. We'll give about another 30 seconds here. Good afternoon, everyone. Thank you for joining us once again for our weekly Wednesday webinar series. Today's webinar is on navigating time and space, experiences of aging with hemophilia. My name is Brett Patel. I'm the Vice President of Advancement here at the National Hemophilia Foundation. At any point during the webinar, if you would like to ask a question, please use the Q&A feature at the bottom of your screen. We have NHF staff members monitoring these questions, which we will post to our presenters after the presentation. This webinar is being recorded and will be available to the community beginning on Friday, November 19th. Today, we will also be live streaming on our LinkedIn and YouTube channels. I'm joined today by Dr. Tam Perry, Dr. Sarah Schwartz, and licensed clinical social worker, Dana Francis. Thanks for taking the time to join us, everyone, and I'll now turn it over to you to get us started.
Thank you, everyone, for being here. I think we'd like to start with introducing ourselves. My name is Sarah Schwartz. I am a clinical associate professor in the University of Southern California, Suzanne Dorick Peck School of Social Work.
Hi, my name is Tam Perry. I'm a faculty member at the Wayne State University School of Social Work in Detroit, Michigan.
And I'm Dana Francis. I'm the social worker with the Adult Hemophilia program at UCSF in San Francisco.
And together, we were the recipients of a 2019 Innovative Investigator Award through the National Hemophilia Foundation. Today, we are presenting the results of our research through this award. Okay, there we go. So I thought I would start with a timeline and a little bit of background information on this project. In addition to being a professor through the USC School of Social Work, I also serve on the board of the National AIDS Memorial in San Francisco. And in 2016, the National AIDS Memorial, in collaboration with the HIV Story Project, began producing 10 to 12 minute mini documentary videos on communities who were impacted by the HIV and AIDS crisis, whose stories are not often represented. So in 2016, we produced a short film on the hemophilia community in AIDS. That film, which you can find on the website of the National AIDS Memorial, moved me into collaborating with Dana Francis and Jeff Mulim to launch a study looking at the intersection of HIV and AIDS. That study occurred kind of around the same time the National AIDS Memorial, NHF, and HFA collaborated to create a hemophilia circle in the National AIDS Memorial Grove, which I'm hoping that some of you have visited. And the work from the original project, which is the blue box, led to our collaboration with Dr. Perry, Dana Francis, myself, Charlie Kaplan, an anonymous long-term survivor, and a group of students for the NHF Innovative Investigator Award that we are presenting today. I wanted to set the stage with the 2016 study. So in that study, I did 32 semi-structured in-depth interviews with 12 parents, 11 mothers and one father of individuals who passed from AIDS related to their treatment for hemophilia. I also interviewed 4 spouses, 2 children, 9 long-term survivors, and 5 professionals working in the realm of hemophilia services. The key findings from that study were that aging was a topic, particularly with the 9 individuals I interviewed, that this is the first cohort of people to age to this age. They have no roadmap for aging. Many of these individuals are also aging with HIV and some with hepatitis. Education was another key finding, that medical providers who, especially younger medical providers who have never really seen hemophilia and what it looked like before the 90s and before synthetic factor products, were unfamiliar with how to treat people with bleeding disorders. And trauma was also a key theme that came out of that study. So building on the theme of aging, education, and trauma, we built this team for the 2019 Innovative Investigator Award, who I mentioned earlier. The anonymous long-term survivor, Dana Francis, Charlie Kaplan, Tam Perry, myself, and then we have 5 undergraduate student researchers, 2 of whom are here today.
They wanted to say hello.
Okay.
Hello. Oh, hi. This is Misha and Abir, and I would just say, as the Wayne State faculty member who worked with these Wayne State University undergrads, they were phenomenal, both in understanding the topic, getting excited about coding the interviews, but also really developing an empathy and passion for this population. It was a great experience working with all the students, and honestly, so much of our thinking was co-developed with the students because they really contributed a lot of different perspectives.
Okay, so now I would like to introduce Dana to provide some perspectives from the field.
Thanks, Sarah. For those of you out there who are sports fans, I've come to think of myself as a social worker in hemophilia on this project as the color commentator to my colleagues, because I have worked in the field for 33 years. And one of the reasons that Sarah and I wanted to do this project originally was just my interest in the older patients who I think are very unique in this sense that if you're over 50, you were born at a time when there was no factor. There was no treatment for hemophilia except icing the joint, elevating the joint, and whole blood transfusions where you just got a little bit of factor from the other person or the protein from the other person's blood, but there really wasn't much for you. And your lifespan back then, if you lived to be 40, that was old. I just had a patient this morning in clinic who told me that when he was 7 or 8, he pulled the Encyclopedia Britannica down off the shelf and looked up hemophilia, and it said that you would live a very painful life and you would die by the time you were 20. And he was 7, and he's a patient who's in his early 60s now. And he just told me how horrifying that was as a kid to read this and realize that he didn't have much of a future. And as it turned out, he did have a future. He's a doctor, and he is in decent health, even though he has a number of the comorbidities from the 80s and 90s, but he's a successful person with a family. And that kind of brings me to the importance of the work, which is that this is a group of patients, people with hemophilia who have beaten the odds in a way. They were very lucky, they know it. And we really want to capture their life stories, what they've been through, how they've survived, what they have learned. And we want to capture that for historical reasons, but also for younger patients and families coming up. I often think about this, that we don't want to depress you with these painful stories, but we do. There's a lot of triumph in them too. And we do want all the families coming forward whose children are going to be in much, much better shape physically and probably psychologically because of the good treatment they're getting. We want you to know what happened back then, because it is part of the history of our community and it's very important. Some of the ways that we hope to serve this cohort of older patients, we really need to work with them to understand, or at least to adapt to helping them deal with the kinds of issues that happen when you get older, since a lot of them didn't think they were going to. They get a lot of their care from the hemophilia team, and now they're going to need to see a heart doctor or a liver doctor or a gastroenterologist or other professionals that they maybe thought they would never even live long enough to see. So we're helping them integrate some of those things into their medical life. We're also helping them look at social issues, retirement issues, financial issues, and this is all new territory. Some of you may know Randy Curtis, who's kind of a player on the national scene of hemophilia, and some of you may be aware that Randy started this thing he's a comedian, he called it the Geezer track, where we started looking at issues for older patients maybe 8 or 10 years ago. And what we're doing with this project really is an extension of those beginnings. The model for the road ahead with this group is that they're going to set the stage for everyone coming later, because the good news is most people are going to live a long life, a good, healthy, long life with their hemophilia. The medicine's going to keep it in check. And I think this group of people that we're looking at right now, who won't be here in 20 or 30 years, but they're going to give us a wonderful way to think about how to age well and in a healthy way with a bleeding disorder. So I'll stop there.
Thank you, Dana. So just quickly, I wanted to talk about this project. So we really drew from theories of aging. So I am I'm a fellow in the Gerontological Society of America. I'm also the president nationally of the Gerontological Social Work National Organization at the moment. So I really brought this thinking about like what happens when people age, and sort of my own training with that. So we decided to look at different realms of aging. So how are people taking care of themselves? How are they contributing to their own families and communities? What does their social network look like? And then what does home mean to them? And we were trying to understand if home had some significance given the trajectory of this population. We also wanted to look at this idea of strategy. Are there things people are doing to age better? Are they doing certain activities? Are they abstaining from other activities? And then are they using these strategies because their perception of time has changed? So there's theories of time that say when you're nearer to death, you may do things differently. Well, we kind of inverted that in this project and thought, well, what happens instead of getting a lifespan shortened to get a lifespan extended and expanded? How does that expansion of one's lifespan affect all these areas of aging? Next slide, please. So we had one aim is we use the acronym APWH, which is Aging Persons with Hemophilia. So how do people strategically select activities to optimize their relationships, select activities and relationships to optimize their current and also future functioning? How are strategic compensations managed for current or impending loss? And then how have these changing conceptions of time horizons affected this population? Next slide. And then ultimately, we want to enhance service delivery, and we definitely have some ideas about that. So thinking of, after examining the emotional, social, physical, and financial needs and barriers encountered by this population, how can service delivery be enhanced? And then what are the facilitators of best practices for serving this populations, and what additional resources are needed? Next slide, please. So we had 3 hypotheses. we thought that people would be strategically selecting activities or relationships. The second one was that people really will have altered their conception of time. And then due to their historical milestones or traumatic experiences, that they might express unmet needs in 2 or more of these areas that we investigated. So those were the hypotheses we were looking and testing and looking at in our interview data. Next slide. So what did we do? Well, we did a study on the West Coast in California. And why did we do that? Because California is a state that has a specialized medical insurance program called the Genetically Handicapped Persons Program. And so we wanted to see, we definitely have other questions in our interviews about sort of how people access GHPP and barriers to access. So we did a California-based study, even though I'm calling in from Detroit, as were the students, because also Sarah's there on the ground and Dana's there on the ground. We ended up doing Zoom, as many people do, because that's the time we live in. And so that had its pros and cons. Sometimes I think people felt comfortable because we didn't come into their homes. But on the other hand, we would have liked to really see how life was going. The other thing we really couldn't capture on Zoom was physical disability. That the screenshot you had really doesn't capture people's gait or sort of challenges, or and even understanding what assistive devices they might have. So, and we're going to now share our themes. So you can just go to the next slides.
Oh, demographics.
Yeah, sorry. So who did we find? We found 27 people aging with hemophilia 50 and older. They were 77% were between 54 and 68, mostly male, mostly white, 52% severe, and then 60% were HIV negative. Next slide. We also took the time to talk to the providers. And we really wanted a range of providers. So we had social workers, nurses, physical therapists, people in administration, mostly women and mostly white workforce. Sarah, I'll let you take over.
Okay, so we have many findings from our data, but here's, kind of a macro perspective on our findings. We did discover that all participants were and had been their whole lives intentionally selecting activities in relationship to their functioning at that time to optimize their functioning. 88% reported shifting time horizons and that their unexpected longevity has affected them in profound ways. So what this means is that this cohort of individuals never expected to live beyond early adulthood. And then when treatment changed and the home infusion program and freeze-dried factor products, expanded longevity, right? And so people began to envision a future. But then HIV contaminated the blood products along with hepatitis C. So that contracted the time horizon. And for individuals who made it through that period of time, now they have this unexpected longevity. So that is really what that's speaking to. The interview data also identified needs specific to healthcare and for people who are aging with hemophilia. And this complements the first project, which also illuminated the same theme. We also identified 2 emerging themes, one around gender, that gender matters, and one around complex emotions related to trauma, stigma, bullying, cruelty, and we'll discuss that a little bit further. So this presentation, given the time constraints, we have decided to focus on just complex emotions, time horizons, caregiving was an emergent theme, and gender matters. So complex emotions. Here are 8 sub-themes that sort of floated to the surface when we were analyzing the data. The conception of time is a complicated thing to think about as a child, to think that you are perhaps not going to live past college or even to college, or you might be in a wheelchair. That is a complicated thing to wrap your head around. Death, probably at any stage of life, but particularly as a child. Stigma, a lot of stigma. This cohort of individuals experience stigma because of their physical limitations as children, because of lengthy hospitalizations where they were perhaps missing long, weeks and months of school, the inability to participate in sports, to have to sit out from PE classes, cruelty. People can be cruel, particularly children. Pain. Joint bleeds are very painful, and it is a type of pain that someone who doesn't experience it can't understand. So many of our individuals did speak about the physical pain and how that impacts their emotions. Homophobia, particularly in the 80s and 90s with HIV and AIDS. People began to hide their identity because of the association between hemophilia and HIV and AIDS in the context of homophobia and fear and stigma. Silence is a complex emotion where, as I mentioned, people began to hide infusion of the blood products, began to not take blood products, right? To just try to avoid contamination. Fear is a complicated emotion. There was fear of relationships, fear of disclosure, fear of death, fear of suffering, fear of pain, and social isolation for many of these individuals, which is all tied into the other emotional states. Here are a few quotes to represent what we're talking about here. So stigma and cruelty. One male, 76 years old, recalls that childhood bullying was a horrible thing, a horrible way to go about things. I think it reinforces a sense of cruelty, which many people so easily drift into sometimes. Another male, 57 years old, talks about having to sit out during PE. And remembers that people would say, look, he has to sit over there with those kids. And it was really a hard thing. And a female, age 54, also recalls PE as a very painful time for her. In elementary school, when we did PE, I couldn't play dodgeball or those kinds of games, but it was almost like, it brought attention on me. Pain. Here are 3 quotes of individuals who are speaking to the pain of joint bleeds. There were moments in the last 30 years that I can point back to, like I had to have been in a ton of pain because nothing got done. This is a male who's 52 and he had some very interesting reflections on years of his life where he really accomplished very little professionally. And now he can see that it was because he was in so much pain. Another male, 74, recalls as a child that he used to go to sleep and hope that it would stop. And he began to cry as he expressed this, that it was just, he would hope to wake up to find that this was a bad dream. And then another male, age 62, recalls, I used to have all these injuries in my hands and my ankles and my legs and missed a ton of school and spent a ton of time in emergency rooms getting x-rays. And those were always traumatic because they would try to straighten out an arm that didn't want to straighten out. This particular individual is somebody who was not diagnosed with a bleeding disorder until his 20s. So he spent a lot of time in the hospitals being told that it was something else. Time. So we have 2 quotes about time. One male, age 67, recalls that we were all told we were going to be dead by the time we were 13. So we always had this short-term timer's attitude towards things. We didn't have to worry too hard because we were going to be dead. And another male, the same age, recalls my mantra since 12 has been that I have 2 years left. So I think that really speaks to some of the complexities of the emotions here. And then silence was also an emergent theme. One individual, 62, reflects, I have lived a lie my whole life. My whole big lie was that I really don't want people to know I have hemophilia. So very few people knew. I would lie about why I was in the hospital. I would lie about anything to protect the lie. And another individual, age 74, recalls after grammar school, which is equivalent to high school here, he's from England, I never disclosed to anyone other than some lady friends that I have or have had hemophilia. It was a secret, really, and until I no longer needed it to be a secret, which was when I finished employment in 2002. So he was referencing stigma in the workplace and being afraid that he wouldn't be able to keep his employment or keep his insurance if people knew that he had hemophilia. The other theme that bubbled up was time horizons, which we talked about a little earlier. And here are three quotes that exemplify time horizons. So one male, age 67, reflects that this golden age of hemophilia where we had factor and guys were living longer than ever and everything was wonderful. And then came AIDS. And then we started dropping like flies. Another male, age 74, recalls that I've never really felt until now that I'm going to live very long. And I worry about that because I'm 74 now. I think I'm going to live to be 80, and that makes me nervous. And then a provider who's a nurse who's been working with this community for a long time, for decades, offers that this is really the first chance that a lot of hemophiliacs have been able to age. I mean, yes, maybe people live to be in their 60s, but they didn't really expect to be living until their 80s. They didn't expect to have this longevity, and so there was little preparation. Then this is a long quote that we think really represents the shifting time horizon. So this was something that a male who's 73 shared with us. He says, I had a completely fatalistic attitude. I did some of the most dangerous, crazy, insane things when I was, let's say, somewhere between, as soon as I got my driver's license, that's when everything went off the rails in terms of, I took the most ridiculous, ... I didn't think I would make it to 20. I was just quite reckless. I guess reckless is a good word, And then around 30, I started to think, well, now we got factor and things are much more in control. And gee, I might be around for a while. So yeah, I definitely modulated my attitude around age 30. I think when factor came out, lipofuscized, I don't know if I pronounced that right, Dana, factor over cryo. The cryo was a pretty crude approach. Not very efficient would be the right word. But when the lyophilized factor 8 came out, then I started to really feel great, except it became 1984 and I'm sitting in the doctor's office and I pick up Time magazine and there is like a 25-page article about all these hemophiliacs dying of AIDS. It was quite upsetting. Another kind of sub-theme from Time Horizons is about preparing for the future and where this cohort of individuals are right now. One male, age 62, says, I'm in a state of questioning, but I have finally got to the point, and it's only been over the last 10 years, that there's this saying, when in doubt, infuse. So many of the individuals that we interviewed were hesitant to start prophylactics, to do anything, any of the new treatments. And so now many of them are kind of moving into, okay, well, let me infuse regularly to prevent these microbleeds. Another individual, age 58, says, I guess maybe I'm thinking long-term because I'm paying attention to money and I'm paying attention to planning. I don't know how long I'm thinking, but that's why I got my ankle fused. It's like, I don't want to take drugs anymore. And that's the last target joint I have on my list. And I'm not going to get any more because I infuse every day. And then we have another participant, age 55, who actually just completed gene therapy a year ago. So he shares that a year ago, I took the gene therapy for hemophilia B. I haven't had any factor for a year now, and my body feels amazing. Like I'm not in pain anymore. Even the really destroyed joints, they just don't hurt anymore.
So I'm going to cover our two last things we want to talk about today, and we'll wrap up our talk by 2:45, and then leave time for questions. So a lot of people talked about, and it was a surprise to us that people talked about becoming a caregiver. So we were definitely looking at people's contributions, but it was really wonderful to see the complexity of becoming a caregiver. So I'll give you some examples. It's gone full circle, man. I'm her caregiver now. He's talking, the second quote, the male is talking about his wife. She needs to be more careful. She used to tell me not to do things. Now I tell her not to do things. The last quote says, I have a little appreciation for these kinds of phases that, that you have to work through when you have a total loss of functionality. And for my parents, my aging parents, they had it. It's like a lot of ways, it's kind of the first experience that, and she's, oh, you don't understand. I don't have my balances. And like, I do understand. Keep moving. So again, I think what was really important is to see that people are contemplating their own aging in relationship to people in their social networks. Next slide, please, Sarah. Okay. Then there's sort of, well, as I'm aging, how will I receive care? So this first quote from a 57-year-old man, my mom is a little bit, someone better can take care of you when you get old. Being a single person, I guess. The woman, age 54, said, I think about who's going to take care of me because I don't have kids. So I think about my niece or whatever. The social worker said, a lot of our men who are older, they didn't get married, maybe because they have HIV, maybe because of something that happened, or they have Hep C and they don't want to pass it on. And so they kind of live alone, not huge families. And so one of my concerns is that you're out there by yourself. If something happened to you, who would know? And lastly, the 63-year-old really talked about something that we've heard in a couple different places in our interviews, and I know others on this call know about. And it's about sort of institutional living places. So this quote says, law does not permit infusing factor inside these facilities. So my ability to be in a retirement/assisted living facility is non-existent. I'd have to go out to the parking lot or have somebody come. I can't even keep factor 8 in the facility with me. The laws have got to change from that standpoint because that's a real challenge for us. Next slide, please. And then another emergent theme was on gender. So we were able to interview women who really highlighted the challenges they'd experienced. So a 68-year-old woman said, I think, unfortunately, we are set aside from being properly diagnosed and treated because they are carriers, right? We were just carriers. A nurse said to us, so a woman can have the same levels as a mild hemophiliac, but because she, by a geneticist term, cannot have hemophilia, the medical professionals will just tend to discount that she has hemophilia. And then a social worker says to us, there's a whole section of blood disorders called von Willebrand's disease. There's that word again. There's platelet dysfunction situations. And because male and female doctors, gynecologists, obstetricians, all of them had a day or two of training in medical school about bleeding disorders, they often don't know what they are looking at. And back in those days, they were sending women home who were having their menstrual period for 3 weeks out of a month and just telling them there was nothing wrong with them. Next slide, please. This woman, age 68, she recounted, actually, I did this interview and it was when she was young. She said, I bled on everybody's furniture, every car I rode in, and it was mortifying. And it's amazing to me that no one ever thought to say, gee, maybe she should see a hematologist. Then we have other stories of sort of in the realm of reproduction. So a nurse said, we had a young child get diagnosed at birth. Circumcision bleeding led to diagnosis. Then after we met the family, we realized that his older brother, age 4, also had hemophilia. signs and symptoms that had been ignored. A 60-year-old woman said, very few women get acknowledged. They get ignored. I mean, where do you think these hemophilia boys come from? And this 58-year-old woman said, this is how I found out I was HIV positive, from a blood transfusion that they dated back to possibly I was positive in 1984 when I had my second son. So we're going to end with a few slides on our recommendations. So we wrote a very long report with the help with the students and all the team members. And we're happy, feel free to get in contact with Sarah or myself if you're interested. But here's sort of the end of our report and what we thought. Well, we really thought there's recommendations for this current cohort, and they're a little different than the next slide, which is recommendations for future cohorts. So for this current cohort, it's really important to recognize the variation within those aging with hemophilia. I mean, that includes gender, but it also includes age, ethnicity, region of the country or the world, and other factors that go into that. Recognizing that change time horizons are really leading to new identities and social roles. This one being a caregiver is one we really honed on to. Promote understanding and visibility of all genders living with hemophilia. So we would love to pursue more on that, or that others take that up. And then, of course, enhance appropriate mental health support and access to services, particularly for such a complex history of illness, pain, and emotions, as mentioned. And then continue ways to render visible this the history of this cohort and this cohort who's made such strides in this this decade. All right, so recommendations for future cohorts. So we think that there's still going to be childhood and young adult concerns of identity and inclusion. They may be different than what our data showed about exclusion from gym class and bullying, but there are probably other ways that identity and inclusion must still be at the forefront. Still need strategy for disclosure in the workplace. I think the other thing that came out is some people who are younger now really need help envisioning the reality of a longer time horizon. This includes financial well-being. It includes choosing a career that makes sense, investing in education possibly, and also investing in relationships. Maintain holistic care offered now at the HDCs. So many people talked about how the HDCs had made such a difference in their lives. And then we add this last thing, prepare for current and future pandemics as they intersect with hemophilia. I know the whole world has been shaken up in the last 2 years. And so definitely we had questions in our interview data specifically about COVID and how people were coping, how their treatment was going, et cetera, how they switched to telemedicine. And so this need to prepare is also there. Next slide, please. We have some system level recommendations. Disseminate information and knowledge to enhance understanding and care in the medical community. So, training medical professionals who may not have as much experience with hemophilia to know how to handle it when they do have someone with hemophilia come in. And we saw that quote of like, people get very little in medical education, et cetera. Insurance community, long-term care facility communities, which definitely as more people age with hemophilia, I think that's something. And then also families, and then ensure effective systems remain where possible, and then enhance existing systems of care. So this includes, making sure that mental health providers have the resources, because people have such complex histories. Dana has told us before, you can't just have an intern meeting people. You need people experienced to serve you need experienced mental health professionals. And then future directions for research. We think that people who are the consumers, the clients, need to be included at all stages of research. So this is a commitment our research team has to community-based participatory research, from designing the research questions to helping find people to be in the studies, as well as in dissemination. Expand the knowledge base, and I think I mentioned this, but gender, race, age, undocumented individuals and communities, and non-English speakers. So our last two interviews we did in California were with Spanish speakers, and it was very exciting to hear their transnational histories. And of course, we need to look at states and places without specialized insurance programs. And then I think we really need to compel ourselves to be innovative with how to reach people with what we find or suggestions and resources. So can we document these stories in films? Can we do podcasts? Can we continually be part of dialogue and blogs, etc.? And so I would say, to sum it up, I think there's definitely avenues to explore for raising awareness of this population in lots of different circles within the hemophilia community, within the gerontological community. I just spoke last week at the Gerontological Society of America on our study, and there a lot of people had never thought about this population and its uniqueness as a cohort. Then we need research to both advance the knowledge base, but also to build a workforce, meaning getting people excited to go into rare bleeding disorders. And in fact, a lot of the students we had this summer, all very interested in pre-med and public health. We realized like their exposure at different stages can help build this workforce. Of course, we need advocacy on a local, federal, global, and statewide level. And then we need programs both within communities, within chapters, as well as at conferences, etc. For both, I think, people aging with hemophilia, but also practitioners. So I will end there. Thank you so much for listening today. We are so excited about this work.
Great. Tam, Sarah, Dana, thank you so much. We do have some questions that have come in. I'm going to start with this one. This one asks, did women in the study share anything about if or how menopause and aging with a bleeding disorder was or was not an impact in their lives?
Yes, that is an emergent theme too. So particularly in the context of women who had been diagnosed with a bleeding disorder and had been retrieving or receiving treatment for their menstrual cycles, once they went through menopause, the treatment went away. And the medical community said, well, you don't need this anymore. You are, menopausal. But that's not the case, because as we age, we have a lot of medical procedures that are done that do require factor products. Like if you have a biopsy or a colonoscopy or any kind of invasion of your body. And so a few women were talking about avoiding getting these preventative medical health services because they didn't have access to products. And then just to add on to that, another emergent theme was vitamin deficiencies, particularly iron. All that heavy bleeding, these women are aging and having brittle bones and a hard time as they get older.
And I would just say, because it's a point that's really important, that the intersection of aging with other things that can happen to you was also part of our interview data, meaning people talked about cancer treatments and strokes and heart conditions and diabetes and other things that sort of navigating concerns and chronic illness among this population was also a concern, both for men and women. Thank you.
Great. We do have another question that's come in through the Q&A from Mark. Mark, it's good to see you out there, sir. Mark asks, from your observations, is there a case to be made for adding gerontological professionals to the HTC comprehensive care teams? To what extent is this already happening?
Let's let Dana take on that one.
Wow. To my knowledge, and it's limited, but I am not aware of that happening at all. I think that's potentially going to be an outgrowth of this research and other research like it. I can't imagine there'd be someone on full time, but I can definitely imagine having someone as a consulting person for a team who could see some of the patients in that age range. some HTCs have arrangements with nutritionists or professionals like that. And I think just to the point of what we're talking about here today, more and more of our patients are going to be getting older. And I really think that would be a wonderful adjunct to what the HTCs are doing. And I think this is why we're trying to talk about this issue now, because that number is going to grow.
Great. Thanks, Dana. Well said. The next question comes in through the chat from Pamela. Pamela asks, is there a published survey that you might suggest HTCs use consistently to gather data from our APHWs?
That's an interesting question.
So I would say, Pamela, that is something that we would be really interested in helping to co-develop. So my training and background in gerontology, I would think a very short list would be sort of a social network scale, of which there are many out there. There's sort of geriatric depression scales. There's also sort of IADLs or ADLs, activities of daily living, surveys or tests, assessments. So I think it would be, there are great geriatric or gerontological surveys, that assessment tools out there. I think it would be great to make a specialized one. Hopefully.
I don't know that one exists, but our team would be happy to work with you to co-create one.
Yeah.
Great, thank you. Next question that comes in. Did you find that adults in this age group were connected to the community, attending chapter events, advocating for different kinds of support now that they are older?
Some yes, some no.
So I like this question because I felt like if I did 2 interviews in a week, someone would tell us they were so active and had been there since their youth, their family was active, they helped create programs, and it was sort of part of their legacies. And the very next person might say, I have never been friends with anyone else with hemophilia. I do not know another person with hemophilia in my social network. So it was very interesting because you have to wonder, well, what was the interest of participating in this study? And in a lot of ways, both wanted to share their stories. So it was really amazing when we saw people who really have had no connection. Yeah.
I'd just like to add to that too, that I think those people in between those 2 extremes struggle with not wanting to be pigeonholed and classified as something having to do with a health problem. And so they flirt with the community stuff and they do get something out of it, but they just also, part of them very strongly wants to live their own life as just a normal person in the world. Yes, they have hemophilia, but they just want to work and have their own friends and not have everything revolve around their condition. And I can certainly appreciate that too.
Yeah, thank you for that. Appreciate it. The next question that comes in is, how are you planning to widely share these results of the study?
Great question. Well, first of all, what have we done to date? So I would say, what have we done to date is we shared this. Sarah, do you have the slide of where we shared it from yesterday? Can you put that up possibly? But basically, we plan to go to academic conferences. We are also very open to speaking at chapter meetings. We have one next week in a location that's not in California that we're excited to speak at. But we also want to, the students are actually developing a blog for Detroit's sort of community public health blog. So I think doing blogs for certain things. So this is good. So last year in 2020, we presented at the International AIDS Conference. We presented last year at the Gerontological Society. We presented last week at the Gerontological Society. We actually will be featured at World AIDS Day on December 1st. Sarah, is there a time that people, if they're tuning in, would find our work?
Yeah, if you go to the aidsmemorial.org, there is the agenda. I think the panel on aging with hemophilia is at 1 p.m. Pacific time. I'm not sure, but it'll be on the website after as well.
And so I think we want to raise this issue in gerontological venues. So next year, Samantha Carlson from NHF and I are going to try to put together a panel at next year's gerontology meetings. We are applying for the conference in Montreal, World Hemophilia
Congress.
Congress. And then I think it would be amazing if we had popular press pick this up, like New York or Atlantic. So we'll see if we have any connections there. We think maybe there could be a website section of NHF. And then Sarah's already on the board of the National AIDS Memorial. So, building further collaborations with them, also possibly making some films. So I guess those are our plans right now. We are very open to getting this work out. Honestly, we're so proud of this work and so excited about the road ahead of what we can do.
That's great. There's a couple more questions that have come in. I will also share really quick that we have a website called Steps for Living, NHF does, and there's a lot of information on aging there as well too. And I will go ahead and throw that in the chat for anyone that wants to take a look. The next question that comes in is, knowing in this particular study it could be difficult, how did you ensure the diversity of participants?
Well, we use non-probability sampling for those of you who are researchers. So our sample is inherently biased, right? We recruited through word of mouth, through HTCs, through a flyer, and we did the best we could do as far as like we knew we wanted to capture voices of women, so we did some targeted recruitment. We knew we wanted to capture some non-English speakers, so we did some targeted recruitment there. But, given that it was non-probability, we did the best we could do within the context of that.
And I also think there's also the Zoom COVID context, which is some of our interviews were solely on the phone because there's also a digital divide that's out there too that we all have to acknowledge as when we provide services. So we had to accommodate sort of access to technology. And we would also say in our California-based study, we tried to do a variation of geography too, not just have people from the big cities. I was really hoping to find someone living currently in long-term care to get their experiences, and we were not able to find that. We wanted probably more socioeconomic variation too, because it's really this whole idea of like what careers you chose or professions one chose when you didn't think you were going to live long, and how did that play out? That would be something to really document. Yeah, and we're really open to continuing this work. We really feel like it's just the beginning. We're excited to share today. This was a big event for our research team and the students who are still here. We just also appreciate that NSJF supported this interesting sort of social science approach to understanding this population.
Right. I do have one more question that came in, and I think this is probably a very appropriate question to end on, and I'll ask each of you to please comment on this, but it states, if funding wasn't an issue, where would you like to be, or where would you like to see the study go 5, 10, 15 years into the future?
Tam, do you want to start, or would you like me to start? Or, I'll start. I would love to see us find a way to continue to capture stories kind of in relationship to the question that was just asked around diversity, and develop knowledge. I definitely am someone that believes we have to understand our history before we move forward, or as we move forward. So I'd like to see this work help with advocacy efforts, with education and training. I am particularly interested in taking a deeper dive into the question of gender. I feel like we could continue with this work for 30 years. Tam?
So I guess I'm a person who's also wanting to think big. It's my macro social work training, and we're all a team of social workers too. So I think that Sarah and I can continue on our projects. We're really interested in the gender issue. We're also very interested in sort of transnational issues around this, because we even heard people crossing over different states to get different services. So sort of what happens when you're kind of in those fissures or sort of border crossing experiences. That's interesting. And we would be certainly excited to expand our own projects. But I would also say it's come to my attention that building the workforce that really understands what it means to age, mentoring people of all different professions to stay in this work and to understand the addition of the aging with hemophilia component might take the form of sort of education, outreach, mentoring programs to people in universities at different levels, doc students, postdocs, et cetera. Even this ability to offer pilot funding to other people who want to do projects related to aging with hemophilia, so that it kind of expands the work. The other thing I think is the awareness piece. I think if we could get more coverage on this topic, Dana always says, like, this cohort's not going to be here forever. So can we make sure that we're acknowledging and honoring them? And so we're very committed to the awareness piece too.
And remembering the kind of historical trauma from this community. And, as we know from other traumatized communities, when we think about World War II and the Holocaust or Japanese internment, or, the trauma goes from generation to generation. And some of these kids who are been receiving factor from day one of birth, have grandparents who have, some physical challenges, and they see that. And that kind of trauma passes down. So it's important to contextualize, I think, what's happened over the past 40 years with this, with bleeding disorders.
This is great and incredibly interesting and work that we all believe should be done and continue to live on here. So we Sarah and Tam, we appreciate you taking the time to be with us today. Dana, who unfortunately had to leave, he's got a clinic there, and the two students that are with you as well too, Tam. We certainly appreciate everything that you've done and appreciate your time here. I'd also like to thank each and every one of you out there for joining us today. Please note that the recorded webinar will be available on Friday, November 19th at hemophilia.org under the events tab, where all of our other archive webinars as well too, along with the schedule of our upcoming webinars. Thanks again, Tam, Sarah, for joining us and presenting the information. We appreciate it. Everyone have a great afternoon.
Thank you.
Bye, everyone.